Peptic ulceration and Helicobacter pylori. Etiology, Pathophysiology, and Pathology. Helicobacter pylori infection and NSAID use are the two most common etiological factors. Risk of peptic ulceration appears to be higher in NSAID users if they are also infected with H. pylori. There are different H. pylori strains, CAG-A being associated with more severe gastritis and intestinal metaplasia. H. pylori is unique in that it produces a urease that is made use of in diagnostic tests. Epidemiology. In the UK, serological testing for H. pylori shows that up to 50% of 50-year-olds and up to 20% of 20-year-olds have been infected. This is a cohort effect and does not mean that 1% acquire the infection each year. H. pylori causes 90% of duodenal ulcers and 60% of gastric ulcers. The lifetime risk of duodenal ulcer is 4–10% and of gastric ulcer 3–4%, males more than females. Clinical presentation. Common. Epigastric pain or indigestion. Lethargy from anemia. Melena and/or hematmesis. Uncommon. If present in the pylorus, there may be gastric outlet obstruction with vomiting. Rare. Perforation with abdominal pain and signs of an acute abdomen. Physical signs. Anemia. Epigastric tenderness. Investigations and staging. Endoscopy. To establish the diagnosis and to take biopsies from a gastric ulcer to ensure it is benign. Antral and gastric body biopsies for H. pylori. Risk of rebleeding can also be assessed in those presenting with hematmesis or melena. NB. Some gastric ulcers are malignant despite appearing benign endoscopically, hence biopsy is vital. H. pylori detection. There are many methods by which H. pylori can be identified. Serological testing for IgA or IgG antibodies to H. pylori is only useful if previously untreated. Samples taken at endoscopy can be subjected to a CLO test or histological examination, silver stain, Figs 29 and 30. NB. Serology cannot be used to assess whether the infection has been successfully eradicated with treatment, as antibodies persist often for decades. 1,3C urea breath test. A non-invasive method of assessing whether H. pylori has been successfully eradicated. More novel methods of detecting H. pylori include measurement of bacterial antigens within stool samples. Treatment. Emergency. Endoscopic therapy can be used to try to control bleeding using injection, adrenaline, and thermal contact devices, electrocoagulation. Short-term. Eradication of H. pylori. Triple drug regimens are effective in 80–95% of cases, e.g. 7 days of twice-daily proton pump inhibitor, PPI, clarithromycin 500 mg BD or amoxicillin 1 g BD, and metronidazole 500 mg BD. Reinfection following eradication of H. pylori is rare in adults. Antibiotic resistance to metronidazole and/or clarithromycin occurs in 10–20%. Some patients require further triple therapy regimens, which may require modification using culture and sensitivities from gastric aspiration. Ulcer healing. 6 weeks of PPI to heal the ulcer. Long-term. A patient who has had a complicated peptic ulcer, bleeding or perforation, should probably remain on long-term anti-secretory therapy, PPI or histamine H2 receptor blocker. If an NSAID is required following a gastrointestinal bleed, then a cyclooxygenase, COX, COX-2 inhibitor combined with a PPI has been suggested, although COX-2 inhibitors are not currently in favor. If NSAID therapy is required after uncomplicated peptic ulcer, consider using misoprostol or a PPI in addition. Complications: perforation and bleeding. Gastric carcinoma. Less than 3% of gastric ulcers are malignant. Esophageal reflux. There is concern that eradication of H. pylori may be associated with an increased incidence of esophageal reflux. Prognosis. Most peptic ulcers heal when a PPI is used, but 20% will develop recurrent ulceration even if H. pylori infection is eradicated. Prevention. Primary. Avoidance of NSAIDs and smoking. Use misoprostol or PPI with an NSAID. Disease associations. Gastronoma is associated with multiple peptic ulcers. May occur in isolation or associated with multiple endocrine neoplasia, men, type 1.